I now invite Dr. Jatinder Singh Bhalla to give his talk on triple drug fixed dose combination in glaucoma management and Indian innovation.
Thank you, Dr. Kiran. Dr. Vineet, that was a very wonderful illustration of the practical concept, how you have evaluated and how you demonstrated that stenting of internal carotid artery could improve and reverse the blood flow in the short posterior ciliary artery. I think that's a great lesson learned from your practical cases. The topic I'm going to cover is triple drug fixed dose combination in glaucoma management. We all know about the fixed drug combination, how they are helping us in decreasing the number of drops that need to be put to achieve the target intraocular pressure. This is, as far as statistics is concerned, glaucoma is the leading cause of irreversible blindness and second only to cataracts as far as blindness is concerned. And what is the Indian scenario? 12 million people affected and nearly 1.2 million people are blind due to glaucoma, but unfortunate part is more than 90% of these cases remain undiagnosed. In open-angle glaucoma, medical therapy is the most frequently used intervention for lowering intraocular pressure and is typically the first-line therapy in most of the patients. And combination of agents are often required to achieve and maintain target intraocular pressure level. And intensive combination treatment leads to considerably greater IOP reduction and prevent the disease progression. And so, as far as the calendar of various anti-glaucoma drugs is concerned, the first drug which came into vogue was pilocarpine, parasympathomimetic, way back in 1875, and it was almost 100 years later that we had in 1978 beta blocker in the form of timolol. Then we had prostaglandin analogs, alpha agonists, carbonic anhydrase inhibitors, and then slowly we also saw advent of various drugs. And initially most of these drugs or various pharmaceutical class of drugs, whether it was parasympathomimetic or whether it was alpha agonist, whether prostaglandin, most of these combinations were beta blockers. Then we had non-beta blocker combination of the drugs also in the form of alpha agonist brimonidine with carbonic anhydrase inhibitors like brinzolamide. So the IOP control is very important to reduce the risk of glaucoma progression, because uncontrolled IOP is a key risk factor for the development and progression of glaucomatous optic neuropathy, and each 1 millimeter mercury decrease in IOP reduces the risk of progression by close to 10 to 20%, and various landmark studies have given guidelines and recommendations for the goals of glaucoma therapy. Like EMGT suggested that there is by 1 millimeter mercury decrease, there is 10 to 13% decrease in the risk per millimeter of mercury. OHTS told us 10% per millimeter mercury. European Glaucoma Prevention Study told us 12%. The Canadian Glaucoma Study and UK Glaucoma Treatment Study said that there is a 19% decrease per millimeter of mercury decrease in intraocular pressure. So there is a guideline recommendations by Asia Pacific Glaucoma Guidelines, CGIC guidelines, and ICO guidelines, which NICE guidelines, which also recommend the use of combination therapy in the management of glaucoma. So what are the issues with multiple medication? Why do we need to have fixed drug combination? Because multiple medication have issues like compliance issue, and there is increased preservative exposure, and there is also washout effect of the second drug, of the first drug after you have instilled the second drug. So it improves, there is improvement of adherence with fixed drug combination, because if you compare the fixed drug combination with individual components, you will find that there are less number of eye drops instilled, washout effect is almost nil, the tolerability is more, convenience of administration, compliance is more, and there is definite decrease in exposure to the preservatives. Preservative exposure with multiple drug therapy is a cause of concern, because it has been found that almost 40% of the patients of open angle glaucoma, they suffer from ocular surface disease, and long-term use of topical drugs, especially in those patients receiving multiple drug regime, have demonstrated various side effects like hyperemia, itching, tear film instability, stinging, burning, and dryness. And the incidence of toxicity can be mitigated by decreased preservative exposure. So fixed drug combination therapies decrease ocular exposure to preservatives and have the potential to improve the patient compliance. So maximum medical therapy concept is the use of 3 or more different classes of anti-glaucoma agents to achieve maximum lowering of intraocular pressure, and because it attempts to achieve the best possible therapeutic outcome with medications and decreases the adverse effects and compliance issues. So availability of 3 or more different class of drugs was achievable in almost 2 bottles, but now availability of 3 or more class of drugs as a single fixed drug combination is achievable with a simplified installation regime. So how many topical drops are too many? This question is a very practical question. If we have one drug which is having prostaglandin analog and bottle 2 is having either beta blocker or ROCK inhibitor, and then we have number of drops may be 2 and number of medicines will be 3. And similarly, if we have different combination, one prostaglandin, another combination of with beta blockers or combination of alpha agonists with beta blocker, the number of medications and number of drops you will find that keep on increasing. So counting instead of what I propose is that rather than counting the medication or number of bottles a patient is using, we should be counting the number of daily eye drop installation that patient has to make. And using that perspective, today's fixed drug combination can allow us to prescribe more medications without simultaneously increasing the number of drops. So these are the list of currently available fixed drug combination. It can be carbonic anhydrase inhibitor with beta blockers, prostaglandin analog with beta blocker fixed dose combination, and non-prostaglandin analog fixed dose combination, where like brimonidine and brinzolamide. So there have been published studies of triple fixed drug combination, which just decreases not only the number of drops, although we are using 3 class of drugs, but the number of drops have really decreased. And these are the various studies which have been published on the role of triple fixed drug combination, right from 2009, where they combined timolol, brimonidine, and dorzolamide. Then in 2012, again we had same combination. So these triple fixed drug combination have tried and tested and published in the literature. And recently a triple drug combination has been developed in our own country for treatment of glaucoma, and trial and toxicology studies have also been conducted for this purpose. And what is the rationale? Rationale is, like I mentioned earlier, that the number of drops have decreased, improved compliance, cost benefit to the patient, and there is ease of adding an additional class of anti-glaucoma drugs. So this triple drug, fixed drug combination of timolol, brinzolamide, and brimonidine, besides the various practical efficacies, we also have the improved, it is acting at various different mechanisms, like there is increased uveoscleral outflow with brimonidine, decreased aqueous humor production with timolol, improve ocular blood flow and improve ocular blood flow with brinzolamide, and there is possible neuroprotective role on optic nerve in glaucoma with brimonidine. So there are various mechanisms by which this triple fixed drug combination has been is supposed to act. So this study was conducted with the primary objective to assess the efficacy of this triple drug combination, and the secondary objective was to study the safety and tolerability of triple combination of this timolol, brimonidine, and brinzolamide. And the various parameters which were assessed were on the first visit on day 3, then after baseline, and then after at week 2, week 6, and week 12. And what we found was that IOP reduction from the baseline to week 12 was close to 10.5 plus minus 0.18 millimeter of mercury, and that was statistically significant. And change in IOP from baseline to end of study, that is week 12, were again statistically significant in all the cases. And if we compared the proportion of subjects achieving IOP less than 18 millimeter mercury at weeks 2, 6, and 12, we found that more than 50% of the study subjects attained IOP less than 18 millimeter mercury as early as 6 weeks, and the proportion of subjects who attained IOP less than 18 millimeter mercury at study end was as high as almost 87%. So general well-being of the subjects, when it was assessed, that more than 95% of the study subject rated as good, because there was decreased side effects like dryness, itching, and irritation. Adverse events which was noted was all just 7.5%, and the proportion of ocular adverse effect and non-ocular adverse effects were noted. Ocular adverse effects were dryness, burning sensation, eye redness, and itching, and all these symptoms were mild to moderate. So because of reduced preservatives, there is definite advantage with triple fixed drug combination. So there are current unmet needs. If the disease progresses despite treatment, IOP fluctuation increase the risk of visual field progression, inaccurate IOP monitoring, and patient non-adherence. All these things can be countered if we give the patient, particularly these elderly patients, just one bottle where they can have 3 classes of drugs. Thank you everyone for your kind and patient hearing.
Thank you, Dr. Bhalla. It was very informative talk on the concept and advantages of triple drug fixed dose combination in glaucoma. Thank you.
If there are any questions, I think you can give to our panelists. We'll be too glad to answer. Dr. Kiran, what do you think of the various drugs, particularly in a patient like normotensive glaucoma or in a patient of open angle glaucoma who has achieved the target intraocular pressure and is also having systemic hypertension? What will the class of anti-glaucoma drugs would you prescribe, and would you recommend any change? Would you recommend to his physician any change in his anti-hypertensive treatment?
See, basically, PG analogs would be a first course of treatment. First of all, because they have a better IOP lowering effect, they lower it by 30% as compared to the and beta blockers should preferably be avoided, especially if they are on antihypertensive, because systemic and topical beta blockers lower OPP, lower the blood pressure, and PG analogs have been known to increase OPP. And they also called nighttime blunting of the diurnal curve. So the nighttime IOP would be better controlled, and hence the ocular perfusion pressures.
Dr. Farooqui, what would be if the patient is already on prostaglandin analog, what would be your second add-on drug? Will it be alpha agonist or carbonic anhydrase inhibitor to achieve the target intraocular pressure in such patients? Because particularly it is said that carbonic anhydrase inhibitor increases the ocular perfusion
Yeah, I'll
pressure.
prefer to use carbonic anhydrase inhibitors, because it does have, there are studies to show that it increases the ocular blood perfusion pressure basically. That'll be my drug of choice. As an additional
Dr. Vineet, do you think all glaucoma patients should have comprehensive, we should assess their blood pressure monitoring? You very nicely told that most of your glaucoma patients also undergo 24-hour BP monitoring.
Yes, sir.
Do you recommend as a matter of routine?
No, sir. I would. So 7 years down the lane with ocular blood flow analysis going on, and I am fortunate enough because my better half, she's in a government institute and she can do it free of cost. So we have to see what is the cost that is incurred to the patient also, and we have not got any specific results which are showing that one drug A is better than drug B or drug C, even after lowering of the intraocular pressure. So we are doing a study where the patient is when diagnosed, a primary open angle glaucoma patient, when he is diagnosed, before starting the medication, he gets his ocular blood flow analysis done, and then after the drug is started, we do it again, and we have not seen any major difference, any statistical significant difference. So I would not recommend it in all the patients, only in those patients where there is a progression even after control of target intraocular pressure, and second is normal tension glaucoma patients there, because the cost in our country is a very, very major factor, sir.
Even after the availability of OCTA, do you still go in for the Doppler imaging?
Yes,
where
sir.
It has a
Now-
lot of limitations
So
as the
now,
body is stressed out.
because we have access to both, sir, so that's why we
It's
can
not a question of
basically-
access, it's a question of would
so
you
OCT
prefer-
angiography per se would tell you about the only superficial things. It would, when we talk about the concept of OCT angiography, it is basically the capillaries which are the macular capillaries and the optic nerve head capillaries. It won't tell you what is going on retrobulbar. When you are doing a carotid Doppler, you can get a retrobulbar. Second thing is, in OCT angiography, you would not be getting the actual access to the capillaries which are at the optic nerve head because of the shadowing effect. Signal strength is a very major factor when you are interpreting a OCT angiography. We have seen that in 6 months OCT angiography, in the same patient, they are getting decrease, maybe because of increase in the cataract. So that is very much limiting factors in the OCT angiography. OCT angiography basically was a technique which was earlier used for the retina people. Now there are studies which they are showing that it may have some role in the glaucoma. Only two things that have been shown. One thing is a microvascular dropout. There can be used as a future progression, and second thing is in those patients who are having advanced glaucoma where the OCT RNFL is basically not very useful. In that cases, if you are seeing that there's a more dropout there, then it is relevant. Otherwise, OCT angiography is also not helping too much in our clinical things.
I agree with the shortcomings, but my question is, it does not tell about the ocular blood flow in totality.
I
the
think
volume.
since we have exceeded our time, we can continue the discussion at a later time. So with
There's
that, we
one,
conclude this.
question.
Yeah.
Yeah, I just wanted to understand, we are talking about maximal tolerated therapy. So what would be the percentage of patients who would need a triple therapy, a triple fixed dose combination to be added? Like, what do you, in your clinical practice, what do you think that?
So ma'am, actually what is happening is, if you can see the data also, the patients who are on the, because we are basically getting a referral practice, so majority of our patients who are having advanced glaucoma or moderate glaucoma, so they are using at least 2 drugs, and we are seeing that maybe 10 years down the line, whatever the data we are having right now, out of them the 50% of the patients would be basically using 3 drugs. So that's why it makes a sense, but how much would be the IOP reduction in long-term studies? Whatever we have got in a triple drug combination is a short-term studies right now. Maybe 5 years down the lane, how much significant IOP reduction more than 2 drugs would be there is still a question mark.
Okay, thank you.
Thank you, sir.